All right. Is everybody here?
Yep.
Yes.
Excellent. So Tommy is not going to be here for today. I'm going to be lecturing. You guys met me earlier. I'm Will. I'm the paramedic. We're going to do chapter 9, patient assessment, part 1 and 2. We're also going to try to bang out chapter 2 later on if there is time. Just to let everybody know, this is my first time lecturing through this software, so I got no idea how it works. We'll kind of see how this goes. So, patient assessment. Today I'm going to give you guys your state exam sheets, and there's something you have to know, and it is the phrase scene safety BSI. First thing we do on every scene is we need to make sure that it is safe for ourselves, then for our partner, and then for our patient. And that's what we're going to cover today, the scene size up. So checking scene safety, taking standard precautions. What do we all think that means? We go to scene, somebody pulls a gun on us or has a knife on us, probably not safe. But there could be other things. We might go to scenes where there are dogs running around. Might go to scenes where we have a chemical incident or something of that nature, and it's definitely a good idea to make sure that you know what these hazards are so you don't just run into it. Standard precautions, gloves, eye protection at minimum, gowns, masks, especially given the current with COVID and everything, we're wearing masks for everybody. And think about anything else you might need to protect yourself. Mechanism of injury or nature of illness. For a medical call, it's going to be the nature of illness. For any trauma, it will be a mechanism of injury. More on that to come later when we do trauma. So nature of patient's illness, chest pain, respiratory calls, altered mental status, anything medical in nature. Number of patients, hopefully it's just one. If it's more than one, probably going to need another ambulance there. And what additional resources may be necessary? Do we need the fire department there? Do we need police there? Do we need the power company there? Do we need utilities? All things to consider. This is a very true statement. The only predictable thing about emergencies is that they are unpredictable and may pose many dangers. There are many times you'll get on scene for a simple chest pain and it will not go the way you've intended it to go. And something else is going to show up that shouldn't have been there in the first place. Go to every scene expecting the unexpected to happen. All right, so let's think about this for a minute, and feel free to unmute yourself, but tell me, what are some threats you think of that could be happening to us when we're on scene?
We could be on a highway where a lot of fast traffic is passing by us.
Definitely, definitely. What else?
There could be a large group of people and like bystanders that were there before us or gathered while we were there, and it could pose a potential threat because you don't know if anyone in the crowd has a weapon or is really emotional towards the situation and what you're doing.
The patient could be highly emotional, possibly aggressive, or even like their loved ones or something that like, because they can be scared of us.
That's a big one. All right, so things to keep in mind. Definitely things to keep in mind. All right, when we approach the scene, first things first, look and listen for other emergency units approaching. We go to calls all the time with fire, police, other ambulances. There's a million stories out there about emergency vehicles colliding with each other. I'm sure near the end of the course, or maybe during orientation in a couple of weeks, we will show you what happens when emergency vehicles collide with each other. On car accidents, is look for signs of collision-related power outages. That's where we'll need the power company there. Traffic flow, that's going to be the police job to handle. Just try not to walk out in front of any vehicles or anything. Every ambulance should have high reflective vests, especially when we're on the highway or the roadside. Should definitely be putting that on. Smoke, don't go near smoke. It's real simple as that. Not our job to go near smoke. Questions on that?
If we approach a scene and someone is trapped in a vehicle and fire still hasn't shown up, but the front of the vehicle is smoking, if we approach just to check pulse, to check if the patient is still breathing and they're unconscious, what would happen in that instance? Are we allowed to approach the vehicle even with the front end smoking, even if we don't do anything to take the person out, just check to see if the person is breathing and has a pulse?
That's interesting. Be safe first. Remember, scene has to be safe for you, your partner, then the patient. If you get injured on a situation like this, an injured EMT is not going to be able to provide care for any patient. Use your judgment. Definitely use your judgment on that one. If you feel unsafe to go near a smoking vehicle, you want to go check into that, by all means. Fire is usually no more than a couple seconds behind us or minutes ahead of us. Just use your judgment on stuff like that. Any other questions? Scene safety considerations. So here's a car crash. What could go wrong here? We could see smoke from there. We could see a broken utility pole. That vehicle definitely hit a pole there. Could be something leaking from that car. That's good. Well, it won't be good. We do see two patients. Looks like they're unconscious, but not necessarily unconscious due to the collision. Could have been a leak inside the vehicle, some sort of an overdose or something that happened. Also, keep in mind that there might be more than just two patients there. Could have been a third patient who decided to run away. Maybe they got ejected from the vehicle. So be cognizant of everything that is available and things that may not actually be present right now that could show up later on. We might not see smoke now, but who's to say in 5 minutes time that vehicle doesn't decide to start smoking or leaking fluids.
Could we enter the scene there though, even because we don't see like the active power lines, or do we have to wait for a fire or someone say, yes, it's 100% safe?
From this picture, I would say we could enter the scene right now, but it's not really a good picture. We'd have to see where the power lines are from there. Typically, scenes like this are going to have what we call an incident commander. For the most part, that's going to be the fire lieutenant, captain, or deputy chief, or maybe even the fire chief. Always refer to the incident commander. They're going to direct you, follow their orders, especially, you know, they beat us to this call. They're going to figure out whether it's safe for us to go there or not.
Is it our decision like me and my, like, let's say it's me and my partner's decision, and we see like a smoking vehicle or power lines down, but they're not necessarily really close to the vehicle, but can it be me and my partner's decision to make the call to go over to check pulse and breathing? Or do we, like, are we better off waiting for fire to give the word and just not touch the scene?
The NREMT answer is you're better off waiting. The field answer is use your judgment. Certainly, if I'm in that situation, I see 2 unconscious patients and fire's nowhere near there, I'm probably going to go over and figure out what's going on with these patients and start calling for another truck there. But the NREMT is going to tell you the answer is always going to be scene safety BSI in any form of question the NREMT will ask you.
Now, if we were to follow the NREMT like guidelines, is there any repercussion for the fact that we didn't touch or go to check on the patients before fire came, even if there is like a chance that we lost a patient during that time?
No, not at all. If the scene wasn't safe for you, there won't be any repercussions. All right, here's some good points here. We're on the side of a road or anywhere. Look out for any other bystander, pedestrians walking towards the collision scene, away from the collision scene. Unfortunately, we're in a time now where everybody has a cell phone and people walking around. Not going to lie, everything you do is going to wind up on YouTube, especially if the cell phones are out. So be very cognizant of that. Ordinarily, we're going to defer all this to the police to deal with. We're not going to handle that. So just keep in mind. So again, here we go. Follow the incident commander's instructions. Put on appropriate PPE. I would say this guy is pretty well dressed to go into any scene. I'm not saying you have to dress like that for every scene you go to, but at the minimum, he had got his gloves on. Now he's got the mask on because of COVID. You want to put a gown on, go right ahead. You should put all of this on before you arrive at scene. Nothing is more embarrassing than you show up on scene and you're not prepared to go. Questions on that? All right. When we're in most scenes, we have what we call 3 areas. We have the red zone, the yellow zone, and the green zone. We're not going to get into a discussion as to how big these zones should be, but let's figure it out. The red zone is sometimes called the danger zone. That's where the incident is at the time. That's where the patients are. That's where the spill is. That's where the car is. That's where all the action is happening. The yellow zone is right in between both. This is usually where we're putting the ambulance and where we're doing the initial treatment of the patient. The green zone is fair game for everything else. So red zone, obviously the most dangerous. Yellow zone, somewhere in the middle. Green zone, pretty much safe no matter what. So let's go back a couple of slides when we had that car crash. That actual car in the telephone pole, it looked like it hit, that's the red zone. I would say if we remember back, there was a road that was close to it. That's probably going to be the yellow zone. And then out of the picture would have been the green zone. We're always wearing all the PPE we need in the red zone and the yellow zone. We're going to put on our PPE and take it off in the green zone. Anybody have any questions on that?
I have a quick question.
Yeah.
In the textbook, it says like once you make eye contact with the patient, it says it's like too late to make like precautions. So it's pretty much like once you make eye contact with them, like however much like PPE you have, like you just have to like go like assess them then, or like put on whatever you can by the time it takes you to get to them.
I would say, I mean, usually when you're going to the call, you're going to be putting on your gloves anyway in the truck, and they'll be on before you even get out of the truck. But you take a look at a person and they're covered in blood and you didn't expect that going on, I'm going to take the extra 5 seconds to put a gown on and put on some splash. Doesn't matter.
Okay.
Safe for yourself, then your partner, then the patient. Person covered in blood, unfortunately, we have to assume that that blood is HIV and hepatitis positive. Even if we know for a fact it's not, we have to assume.
Okay, quick question. So you did say the green area is like the safe zone. So would the back of the ambulance be considered a green zone, or is it just outside of the vehicle?
Would be outside of the vehicle. The back of the ambulance is probably going to be the yellow zone.
Okay.
Any other questions? All right. Threat of violence. A lot of calls we go on, there's going to be some pretty violent stuff going on. Fighting, loud voices, weapons, not good signs. Another big thing to understand, unusual silence, which is the exact opposite, is also not a good sign. There should be moderate amount of sound on scenes. Every time we go to pick up some sort of a drunk or a drug overdose, these have the potential to become very violent. When we wake someone up with our Narcan, usually the first thing that happens is they start fighting with us. We ruined their high and they don't like that. They're going to take it out on us. And a lot of times we're picking up alcoholics, they're under the influence of something. So you got to be prepared. They could be very calm, but in a split second, things can turn bad pretty fast. So this slide right here is pretty good to understand all the things that could go bad. What else? Let me see. This can also occur anywhere at all. We can go to the best kept house you could think about, the best, most expensive house you could think about. And
all right, we here. My fault. I couldn't get it to work. I don't know why my mic was tripping, but I'm here.
Okay. Can you hear me?
Yeah, now I can hear you. I switched laptops. We Gucci now.
All right. Sounds good.
I appreciate you.
Sounds good. Where was I? Expensive house. Expensive house. All right. So yeah, sometimes we do go to some pretty expensive houses and they can go either way. These can be the most violent scenes imaginable. They could be the easiest scenes imaginable. That the side of the road, that could be a violent scene. That could also be a very easy scene. As I said in the beginning, expect the unexpected. Always be cognizant. And quite frankly, if the situation turns bad pretty fast, have a way to escape. Don't be afraid to say situation's not safe. I'm leaving until it's safe. No one's going to fault you for that. Any questions on that?
If let's say that, like you were saying, make sure that the scene is always safe and find an escape route. Let's say that, we're on a scene and, at first everything's fine. We try to start providing care for a patient and all of a sudden gunshots start going off towards the person. I mean, I know obviously you want to try to get the patient out as well as, you know, yourself, but if we're always thinking about just like, if I'm always thinking about me and my partner, if we can't get the patient out, is it okay if we take the vehicle? I mean, I know obviously you don't want to drive off scene, but if it continues where gunshots are being fired towards either my direction or a patient's direction, should we just drive off the scene as far as we can and then still wait to know if we should return, when and if we should return back?
I would. If I'm caring for a patient and gunshots start, I'm leaving that scene till somebody else comes and takes care of it. I don't have a bulletproof vest. I don't have a gun. Quite frankly, I haven't been taught how to shoot somebody. So I'm leaving.
What would you say to the patient if you're by yourself?
What would I say to the patient? That's a very good question. I don't know if I'd have to think about that and get back to you guys around 1 as to what I would actually say to the patient.
So would you, in that moment, because I know sometimes, a lot of times police don't show up on scene with us. And in the case of like, you know, someone, it's not like a weapon, like it's not like someone was shot. Like when we pulled up to that scene, it wasn't like someone was shot or stabbed or physically harmed by another human being. But if we show up and, you know, all that starts happening, but it came in as, you know, allergies or anaphylactic shock or something like cardiac arrest, and then that violence started happening, like, do we call the cops? Because obviously cops wouldn't pull up for like a cardiac arrest or anaphylactic shock that's on, you know, the EMTs and like firefighters mainly.
Part of the answer to that question is it depends on the department. There are still, or it depends on the city. There are still many cities that will send fire, police, and EMS to every 911 call. There are some cities that won't. Absolutely call if you need it. Always keep your radio with you. Call if you need it. Somebody will be there as quick as they can. Cardiac arrest, I think by state law, has to have police at all time, especially if we don't transport the cardiac arrest. Then it becomes a crime scene, and that's police matter, not our matter. Any other questions? All right. So let's think for a minute here. I want to hear some ideas. What kind of calls do you think we're going to go on that's going to have our highest threats of violence? And I'm going to add another question here. What do you think we're going to go on that poses the lowest threats to us?
Like a call, just a home calls, like
Any
let's
calls?
say like you head to an apartment or a housing complex.
Mhm.
Like a domestic violence call?
Yeah, that's what I'm thinking of.
That's
Gunshot victims or stabbing victims, somewhere where not only one person was involved can pose one of our highest safety threats.
Yeah. Like fire scenes, stuff like that. Fire-
Overdoses, just because of the demographic and where we might be going. We might be under the bridge where there's a tent city and there's a lot of other people there that could be hostile.
And the lowest ones are the lowest potential of like risk could be when we show up at a hospital to do a transfer to a home, and we're just bringing a patient from the hospital to their home, or when we're bringing like an elderly person to a elderly center. But yeah.
All good answers, all very good answers. A point they want us to make here is, well, we've already talked about, I think, highway responses there. hazmat incidences, especially if the hazardous material is odorless, colorless, and tasteless. And another thing is, again, it's 2021, we got to think about terrorist threats. A little bit about me. I took my EMT 3 months after the Marathon bombing. That was probably a pretty bad situation for all the EMTs and medics who were there. And very violent situation could go off there. All right. All right, so why has EMS been called? Like I said, mechanism of injury, that's a trauma. To answer the question, yes, a simple paper cut meets trauma definition. It is a mechanism of injury. Nature of illness, anything that's not related to trauma. Understand though that these are general terms. Nature of illness could have caused a trauma, and a trauma could have caused a nature of illness. There are certainly examples of both things occurring on the same call. Here we go. Here's a trauma. All right, so this is a car crash. Looks like a pretty bad car crash, although there definitely has been probably extrication. We got the windshield spider webbed, means somebody probably hit their head off the windshield. I don't see any seatbelts cut, so they probably weren't wearing any seatbelts. Not so sure if there was an airbag that deployed there or not. I can't really tell. Looks like the road might be a little bit on the wet side, so that probably caused it as well. It's dark out, so there's a factor going there. What other forces could be at play here? Person could have smacked into the steering wheel with their chest. If they were wearing a seatbelt, we could have the seatbelt compressing their vital organs. There's some forces there depending on how this car got hit. Could have been T-boned, a head-on collision, a rear-end collision. All these things could cause other things, cause different forms of injury, whiplash being one of them. The head snaps forward and back, usually not too good. So also this could have been a rollover, and that presents multiple points of injury there. This is all just from one picture. Anybody have any questions on that? Mechanism of injury. So we already saw this picture. So what do we think is the mechanism here? What do we think happened?
Someone could have lost control on the road and went into the fields surrounding the highway or the higher speed area, and just slammed into a pole. Could have been like a heart attack, behind the wheel, drug overdose.
Texting and driving.
Yeah, texting and driving.
Were the doors open before or after they crashed?
We don't know. We don't know what caused. Again, it looks like they're both unconscious. We don't know what caused it. Just by looking at it. All those things could happen.
Oh, I didn't realize that you had, like, I forgot to tell you that Rosa stays on the phone with me in the class because she can't get access to the class. Just so you're aware, she's been on the phone the entire time. So some of my questions I'll let you know if are asked by Rose as well.
Okay, no worries. Head-on collisions, especially up and over injury patterns. So what we're looking at right now is called a spider web windshield. That usually means somebody's head made contact with the windshield. Now, windshields are not designed to break, they're designed to spread the force out. And a lot of times windshields are designed to withstand some pretty significant force. So a person's head hitting the windshield, even if they may appear fine, they're not fine. If we see this by itself, they could have no other injuries. This by itself meets definition for major trauma to a patient. Oftentimes, when we see this kind of an injury, it means that the patient was not wearing a seatbelt. It means they were speeding. And it probably means that their chest and most likely their abs hit the steering wheel. And that itself, if we think back to your anatomy lecture, what's in the chest, what's in the abs, those are our vital organs. And think about all that force going right into the vital organs. Now we have potential for some internal bleeding and broken chest bones, all that kind of good stuff, which is never a good sign. Any questions on that?
Not really a question, but I'm not sure if you can see the text box where we have the chat. Jessica was letting us know that something's wrong with her mic.
Jessica, do what I did yesterday. Exit the thing and come back onto it. Because yesterday my mic wasn't working for half the day. Just try to exit and come back on.
Jessica, let me know in the chat if you can still hear me.
She's going to leave and come back.
All right, sounds good. Technology isn't good. I've already done a year of medical school online through Zoom, and half the time it didn't work.
Tommy,
Yes?
didn't the glass break a certain way?
Yes.
Like, wouldn't it cut you though?
Not necessarily. It could cut somebody, but depends on how much actual force hit the windshield. There might be a couple of cuts there.
Oh, okay, I understand now.
Yeah.
Is that why when a windshield is cracked, we, like, even if you're just driving on the roadway and a windshield is cracked, because how you were saying how if your head hits the windshield, it's supposed to spider out pretty much to stop, like, full, I don't know, but if it was cracked already, doesn't that mean that the windshield's already weakened?
Hey, can y'all hear me?
Yes,
We can hear
Okay,
you now.
thank you.
no problem.
I don't know a lot about how windshields are designed. I would assume if it's already cracked, and then your head hits it, things could get worse. But I don't really have the answer to that question, to be honest.
Okay, just figured I'd ask. Thank you.
More on head-on collisions. There is a chance that we didn't go up and over the steering wheel, and instead the patient's body went down and under the steering wheel. So what are we going to see there? We're going to see knees hitting the dashboard. We could see feet getting crushed, and that in itself could cause knee injuries, leg injuries, hip injuries, pelvic injuries. So that would be our down and unders. You're going under the steering wheel or over the steering wheel. Oftentimes, again, we weren't wearing a seatbelt at the time of the incident. This is why seatbelts are important.
Is it possible to do an up and over injury if you have your seatbelt on? Because isn't that supposed to stop you?
It's possible. You'd have to be driving pretty fast for the seatbelt to fail. But yes, you could wear a seatbelt and still go up and over.
So in this picture, I can realize that the man has the seatbelt buckled, but it's behind him, but you can't tell if it's over his waist.
Yeah, that's hard to tell from that picture.
Okay.
He's probably just wearing the lap portion of the belt. He definitely is not wearing the shoulder portion of it. All right. Rear end collision. Here is where we're going to find a lot of our whiplash injuries. So your neck goes forward and then snaps back pretty violently. Neck pain is going to be very common. We're going to collar these people. We're going to collar anybody in those sort of trauma injuries to begin with, but be cognizant of a whiplash injury on all rear end collisions. And oftentimes the whiplash itself is a delayed pain, so they might not be in pain the second we show up, but it could have occurred. So keep that in mind. Usually it's at a higher rate of speed, but you could get whiplash at lower rates of speed as well. Questions on that? Rollovers. These are always fun to go on. So I think we can tell from this picture, the car is not on its four tires. That means that the person has rolled their car. More often than not, rollovers are going to be the reason why we go for motor vehicle ejections. A person has been thrown from their car. Other times we see ejections on convertibles. Let's think for a minute about what happens if a person gets ejected. Cars rolling over at 50, 60 miles an hour and you get tossed from the vehicle. Your soft body is now hitting a tree or another vehicle, or maybe it's hitting the ground at 50 to 60 miles an hour. Think about the forces that are on someone's head or someone's body at that time and how much different injuries we can have from that.
So is the base of this that we're supposed to anticipate what we're walking into as we get called to the scene to more or less know how we're going to assess them?
That's one point to take away. Keep
Okay.
in mind, all this stuff could happen.
Okay.
Also to look when you're pulling up, to one, be careful because you don't know if somebody was ejected onto the roadway, and to two, scan the area to see if you find any other, it could be a child or another adult or teen body like laying, it could be feet from the accident, a couple yards from the accident, just to make sure that, because when I've seen accidents like this on TV. I've never seen them in person, so I don't know. But when I've seen them on TV, sometimes people have been ejected feet from the actual location of where the vehicle is. So in that instant, would you have someone scan the area? Would that be like the EMTs and paramedics, or would that be like cops and fire trucks? Or because obviously more than likely one person is still in the vehicle.
Mm-hmm. That's going to be a fire and police job to look around for any additional patients. And trust me, they'll find patients. They will absolutely find them. They'll direct you to anybody who they find. And they'll be doing that while they're also getting anybody entrapped in the vehicle out of the vehicle for you. But you should also, on your own, take a quick look around and see if you can find anybody.
And if you pull up to the scene and there's no one in the vehicle, and you don't find anyone on scene, do you have to just assume that the person who got in the accident ran off? Or do you still have to look until you find someone?
You still have to look, defer to fire and police to see how long you're going to look for. I can tell you most departments around here, they're not looking for more than a few minutes before they decide that the patient left.
Okay.
It is what it is. Severe falls. Adults, more than 20 feet. Children under the age of 15, go with the rule 2 to 3 times the child's height for a fall. These go to trauma centers. Even if the patient seems fine, you got to take them to a trauma center for a severe fall. Severe falls, if they land on their head, that's not good because now your brain's taking the entire brunt of that force. Landing on your feet, assuming your legs haven't broken, your spine's probably going to be compressed. Landing on arms, you're going to break arms as well, landing on anything else. So patient could seem absolutely fine. And there are stories out there of people falling off roofs 20, 30 feet and being absolutely fine. But we got to assume that because of these falls that they've taken, they are injured and they are going to a major trauma center. Now, that does not mean minor falls need to go to a trauma center. You know, at 1 in the morning, grandma wakes up to go to the bathroom, doesn't use her walker and falls out of bed, probably doesn't need the trauma center. Grandma falls down 2 flights of stairs, needs the trauma center.
And what about if the patient refuses care at that point? It's no longer our decision, right? Or
what I
like, well, a competent adult, if they're still able to talk and stuff to you, even if they did have a severe fall, but they are like nothing seems to be wrong, but definitely could have internal injury, and we would obviously say that, but they're just like, no, we're good. We don't need help. I want to get off this truck, whatever. So like in that instance, we just tell them, hey, like these are the risks. You're accepting of these and understanding. So whatever, you know? Or like at that point, it's no longer their decision, it's ours.
Yeah, refusals are another beast in their self. Ordinarily, most refusals are, any refusal is going to be against medical advice. We always have to advise that the patient comes with us to the emergency room, no matter what. Refusals basically state we've told the patient the risks up to and including lethal injury or illness. The patient understands the risks and they are releasing us of liability. They accept any risk. They accept that they could, in fact, die from their injury or their illness, whatever it is they've called for.
The mechanism of injury.
Go ahead. Okay. In cases of significant medical incidences or significant traumas, we can't just let them refuse. What we have to do at that point is you got to call medical control.
Okay.
And medical control is a recorded conversation between the patient and the doctor. So the doctor is going to listen to what you have to say about this patient and you'll paint the picture. I've got a 35-year-old male who fell 20 feet off of a roof, landed, denies any loss of consciousness. Here's what we found for assessment. We found some minor cuts and bruises. Here are the vital signs. Here's the patient's medical history, medications, allergies, and all of that. Doctor, at this time, the patient is requesting to refuse. Can you speak to the patient? The doctor is then going to speak to the patient and advise them of all the risks and tell them on a recorded line. Sounds like you have a significant problem here. You have a chance of a major, major injury, and there's a big chance you can die. Now, we can't force you to go, but you have to tell us you understand the risks are you die. It's a recorded line. The patient will say, I understand that. And the doctor will say, you know, call 911 back if you change your mind, and will let us know the patient can refuse. That way there, if anything bad does happen, the state, the lawyers, everybody, they're going to pull the recording and listen to the patient's voice in their own voice, say, I understand I can die from this. And they made the choice. But yes, patients have the right to refuse. They have the right as long as they're competent and understand what's going on. They're alert and oriented to person, place, time, and event. They have the right to make a bad medical decision. Nothing we can do about it.
This might be like a dumb question, but you know, I know obviously for the obvious reasons, like we can't, you know, I know we can't make a patient come with us if they're competent and of age and, you know, make their own decision to refuse treatment. But why is it other than like the fact that like, you know, the state of Massachusetts law is that we even allow patients who, you know, we know had a severe fall in that way. Why is it like, even if they are confident speaking and, you know, expressing themselves, why is it okay for us to just like, oh, okay, yeah, no, you're good. Then after we've explained everything, they get off the truck. Like, why do we allow that, even if they aren't unconscious or unresponsive?
For the same reason you just said, they're of age, they are mentating correctly, they understand the rules. Unless you want to be charged with kidnapping and be my guest and try to take the patient, you can't really do a whole lot, unfortunately. Does that answer the question?
Yeah, I guess I was just like looking for like a different like answer in a way, but that's, I mean, obviously that's like the case, but because it's Massachusetts and that's how we operate. But I was just like looking for like something that like even, I don't know. Ignore that question. It's fine. Thank you.
All right. Severe falls, like I said, height in which the patient fell, the 20-foot rule for adults, 2 to 3 times patient's height for kids. Surface they fell onto, falling into the bushes is very different from smacking into the concrete. Part of the patient that hit the ground, head injuries are a lot worse than any other injury we can think of. And anything that interrupted the fall, you know, could have fallen out of a tree and hit a couple of branches on the way down. That's going to be important. Could have broken things before they hit the ground. Keep all of this in mind when we're assessing a patient, because hospital has to know this information. That's going to dictate what they do at the hospital to treat the patient. Questions on that? Stabbings, low velocity knife injuries. A lot of these are going to be our superficial injuries, cuts, minor punctures. Look for multiple stab wounds. Usually, person stabbing somebody, they're not just going to shank them once and walk away. Going to pull that knife out and keep going.
He said shank.
I did. I did say shank. Important point, if the knife is still embedded in the person, leave it in. We don't
Yes,
take things out.
we just wrapped them up.
Yeah, we're not surgeons. We don't take things out.
Mhm.
Those are our low velocity. Medium velocity trauma. Here is our handguns and our shotgun injuries. High velocity are our rifle injuries. Gunshots in general, it depends on the firearm that was used, and it also depends on the caliber of the bullet that was used as well. Smaller bullets tend to do less damage than larger bullets. You're not always going to find an entry and an exit wound. You should look for both. Entry wounds are going to be small compared to exit wounds, which are usually large. Not always going to find it if, you know, there are cases of the bullet hitting a bone and being deflected elsewhere in the body. There's not a lot we're going to do for it except stop the bleeding and go to the trauma center, but on gunshots, hospitals do need to know, to the best of your ability, the kind of firearm that was used and the caliber. And if you find multiple entry wounds or any exit wounds.
So how are we supposed to know the caliber of the type of gun? We just supposed to know by the marking of the actual wound?
I believe there is a way to do it based on marking, but on all these shootings, there's going to be police there, and more
Ah, okay.
often than not, they're going to know. They've been
Okay.
trained in that.
So they'll let us know he got hit by a 45 or
Yes,
9mm. All right,
they should.
good to know.
And this is where if we have to cut off garments, we're not supposed to cut through the bullet entry wound. Obviously, try to cut like anywhere else so it can be saved for evidence.
Yes. Cut around bullet holes, cut around stabbing holes. That is all evidence that they need. All right, blunt force trauma. So we just talked about car crashes. A lot of that is blunt force trauma, but this is any trauma you can think of that does not break the skin.
So fist fights.
Fist fights, yep, baseball bat to the head, iron pole to someone's body, you name it. These signs you may or may
What's
not
the worst one you've ever had? What's the worst one you've ever had?
in terms of blunt force trauma.
Yeah.
I've taken somebody who had a baseball bat to the face.
Oh, good God.
Wasn't pretty.
Who
Was
cheated
not.
on you? That's crazy.
Yeah. Though they're not pretty to do that.
Like, so, okay, so wait, how does it work? Like, do you usually get the backstory in the moment or does it all come out afterwards?
I'm gonna go ahead and say there's a 50-50 chance on that one.
Okay, because I know getting the backstory is kind of important to understanding the circumstance and how you go about it. Because I know within that whole circumstance, the first thing you want to do is also protect yourself while dealing with someone who's all in a violent matter. But I don't know. Seems kind of crazy to me.
Do your best to get your backstory. You will be dispatched, and you're going to be dispatched to these calls based on how much information dispatch has been able to figure out. And then do your best from there. It's perfectly okay when you get to the hospital to say, I don't know. We don't know at this time. You know, show up and say, we have an unconscious patient who was involved in a street fight, and we don't know if any weapons were involved, but these are the injuries that we found. That's perfectly okay. The doctors should not scream at you for not knowing. And if they do scream at you, that's on them. They don't know what we do in the field. So.
That's right.
When you're really going on trauma calls, you need to know anatomy as well as you can, because signs are often very subtle and easily overlooked. You could have a person who very simply got punched. Very simply, a nice, easy punch to the body. But for all we know, that punch was right over their spleen and now they're bleeding out. You might not see it initially, but eventually when, a punctured spleen is a surgical emergency, that has to be fixed pretty fast. And you might not see it immediately. It's going to take a few minutes or maybe an hour or so for the signs to actually show up. So car crashes, falls, assaults, not involving knives and guns, those are our blunt force trauma patients. Questions on that?
So you just said in blunt force trauma, assaults that don't usually have a gun or knife involved. But even if a gun or knife are involved, aren't we supposed to still be suspicious of blunt force trauma? So that way we can tell, like that way, because it could also have been like a fist fight that went wrong, but we don't know that with a gunshot wound patient right away because we're too busy on the gunshot or knife wound.
Absolutely. Always, like at the beginning, walk into a call expecting the unexpected. Very common fist fights turn into shootings and stabbings. Very common. Expect the unexpected. Right. Nature of illness. Here are our medical calls. So medical calls, we can't determine a mechanism of injury because there probably isn't one. What are these kind of calls? Chest pain, shortness of breath, psych calls, diabetic emergencies, anaphylactic shocks.
Broken
Allergic-
ankle.
Hmm?
Broken ankle.
That would be mechanism of injury.
Oh.
Mhm.
Good to know.
Headaches, nausea.
Nausea, vomiting, headaches, strokes, all of these are nature of illness. These are medical calls. These are the kind of calls where the patient will have what we call a chief complaint for us. The chief complaint is pretty much the reason why the patient called 911. You know, hey, I'm 65 years old, I'm having some chest pain. That's why I called. That's the nature of illness. Information. Now, obviously, the best form of information comes from the patient themselves, assuming they are able to give you information. For kids, your best form of information is probably going to be parents or caregivers, but there will be hopefully family and bystanders on scene who can help give you information as to what's going on in the scene itself. We go for an unconscious patient and your partner taps you on the shoulder and says, I just went looking for the patient's meds and hey, I found a bunch of insulin. Maybe this person's unconscious because they got no blood sugar. Probably figured it out from there. Use all of these resources to try and piece together what's going on from the scene. Questions on that?
When would an EMT, so if we pulled up to a scene where someone was unconscious, from like the insulin example, and how do we make that assumption that it's insulin and it wasn't a fall or someone banging their head or just genuine fatigue? How do we, because I know like it says don't make any assumptions, but and stuff like that, but one, how would we be able to tell that that's exactly the problem? Or, and also, like, when would we have the time to go and search a home if someone it was unconscious? Because we would need two people.
Well, I'll give that answer in two parts. Hopefully you got other people on scene with you. Firefighters are there, ask them to go look for a list of medications. I'll ask your partner to go look for a list of medications. You find the insulin. I'm not saying that it is a low blood sugar problem. It goes to the top of my differential list of what's going on, but next thing we would do is take a finger stick blood sugar and see what it is. Sugar's normal. All right, it's not a sugar problem. We got to figure out some other reasons why this person's unconscious. Then the fall comes into play, then heart rate comes into play, blood pressure, dehydration, all those things are starting to come to my mind as to what's going on. So yeah, don't make assumptions, but use the clues to help guide you down the path you want to go first. Does that answer it?
Yeah, sorry.
Number of patients. We hope every call we go on, there's just one patient for us to gather. That's not always the case. We saw in that picture earlier, there were two patients in the car. We got two patients there. They were both looked unconscious at the time. We probably need a second truck to show up. So that's where sufficient resources on hand comes into play. We're the only ambulance, we got two unconscious patients. Do we think we got enough hands to handle this scene, or do we think we need to invite someone else to our party?
Invite someone else.
Yeah, we're inviting someone else to the party at that point. I probably shouldn't say this, but I will. MVAs at 2 in the morning, especially if you smell alcohol, you're missing a patient. You're always missing a patient at that point.
Wait, what is it? I'm sorry. Can you re-say that?
Don't write any of this down. MVA at 2 in the morning, especially if you smell alcohol on the patient, you're probably missing somebody.
Good morning.
NV.
MVAs, motor vehicle accident.
Oh, yeah, okay.
Mhm.
Good morning.
Are you able to transport more than one patient? Say they don't need the stretcher? Like, can you transport 2 people if it is, say, just drunk intoxication?
That largely depends on a number of factors. Technically, in Massachusetts, our ambulances are able to handle 2 patients at once because we have a bench seat and we have a stretcher, so you can have 2 people lying down in the ambulance. That's a judgment call on your part as to whether or not you want to handle it, and that's also a patient situation. I'll take 2 patients from an MVA if they're both complaining of absolute minor injuries and I don't need to put anybody into spinal immobilization. I'll take 2 patients. I'm not taking 2 patients if one of these patients is a bloody mess and unconscious.
Yeah, that makes sense.
So another thing to think about is if we're not using a stretcher in Massachusetts, they can technically ding you for not using a stretcher. That being said, it is entirely your judgment call. Entirely your judgment call there.
So this is actually a question that I've like, have thought about a lot, but what about if you pull up to a motor vehicle accident and the child in the back seat is perfectly aware, conscious, is fine, but the adult is unresponsive and needs transport? Do you bring that child with you to the hospital or do you give the child to local authorities?
Chances are if one person in the car is unconscious, there was enough force there to cause damage to everybody in the car. So everyone's being transported to a hospital.
Right.
But if the baby is showing no signs of like injury, do we transport the child with the mother in the same truck?
Mom's unconscious, baby's not, I'm calling a second truck for the baby.
Yeah.
Yeah.
You don't leave, though, until the second truck's arrived, though, right? If you're the only one on scene?
That's going to be another judgment call. Do I have time to stay here and play with mom who's unconscious for a few minutes to wait for another truck? Or is mom circling the drain and we got to move?
Yeah, I think you gotta roll.
Base that on the patient.
There'll be fire and police things. So.
But that wouldn't be patient abandonment if we left the child?
Technically, no, because
Okay.
you do have firefighters on scene, and the vast majority of them are EMT basics. And the vast majority of our departments around here are certified to the BLS level. So they would be on scene and it wouldn't be abandonment as long as they're going to wait on scene for a while. They got to wait for tow trucks and everything. So they'll definitely take care of the kid until ambulance number 2 shows up.
Now, let's say that the mother is just unresponsive and like it was like she kind of just got knocked out in a way in the accident and her injuries aren't so severe where actually no, never mind. Sorry.
Okay. A lot of this I'm going to tell you is you got to play it based on the patient's situation. All right, so what other resources can we need? Fire, technical rescue, hazmat response, police, you name it, we can probably get those resources there.
Yeah,
And
the
if-
silent action hunt.
One more time.
other additional resources? Does the situation require specialized resources, fire, technical?
Yeah, you'll be making that decision when you show up on scene. All right, last slide, just some things to think about. What are the risks to me as a responder on a poisoning or an overdose call? Well, I think we talked about violence. We talked about hazmat situations for substances that are odorless and tasteless. We don't want to go down as well. Routes of entry into the body, stabbings, gunshots, somebody overdose on something, underdose on something. Did somebody snort something? All these things happen. And what can we do as EMS to prevent these kind of things? You know, we're going into that house. We see that we got a young infant walking around, but what's under the sink isn't secured and locked up. Think it's something we should say to mom and dad on scene?
Should
State
probably advise them to lock it up.
Yeah, I would advise them to lock it up too. We're
Are we,
going, go ahead.
I was saying, are we mandated reporters? Do we have to say something and report them?
We are mandated reporters, but only if we suspect that there is child abuse or neglect going on.
So if we walk into a scene and there's like hazardous materials, is it not suspicion that perhaps the child is in danger because they can get into it and the parents are not properly securing this hazardous material? Like if it's a meth lab and we see a baby in there.
If it's a meth lab, yeah, if it's a meth lab, I'm filing a report on a meth lab, obviously.
Okay.
Regular scene with the contents under the sink not locked. I don't know if I'm gonna go that far to file a report, especially if the kid is 100% fine. I might mention it to the parents and I might mention it to fire or police on scene and say, hey, you guys might want to do a follow-up.
Okay.
Later on.
So, I lost my question. Hold on. Sorry.
So on a scene like that, if we did suspect neglect, things were unsafe, and we're clearly mandated reporters, do we tell, okay, so we remove the baby from the scene and like give the baby to the police that are, I'm assuming, outside or downstairs. Would we be calling like social services, or do they handle that part? Where's our like cutoff point?
The answer to your question is both. They are going to call social services. We are going to call social services. In Massachusetts, we have to fill out something called a child at risk form. It's a 51A form. And here at Cataldo, you'll fill it out. You'll put it in the paperwork box for them to fax to child services. And you will also make a phone call within 24 hours of you filling out that form. And the
Okay.
numbers are on the form and everything. As long as you're not doing it maliciously, you won't be in trouble. You do it in good faith. If you fill out a form maliciously, that's a problem.
If we call and child services tells us to remove the child from the home, but it takes a little while, are we like in charge of staying there, or is that fire and police, or what's the deal with that? Like, do we stay if the child's going to be removed from a home?
The answer is we're not actually removing the child. That's going to be Child Protective Services. We're there to render EMS care and transport the child to the hospital. We're going to notify them after the call is complete. Any other questions? Do we want 10 minutes or 15 minutes?
I'll take 15.
All right, 15. Let's be back at 9:55.
Thank you.
All right.
Thank you.
Absolutely. All right, is everybody back?
Yep.
Yes.
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 Sounds good. Patient assessment, part 2, the primary survey. So when you guys come in, I'm going to give you guys your exam sheets today. Let me just pull open the sheets here. Oh, did I print it?
When
I
you
did.
say exam sheets, these are our exams for our state exam or for you guys?
Your state exam sheets.
Okay, the state practical.
Yeah. So I'm going
Okay.
to give you your state exam sheets. And when you get here, we'll talk more about them. But right now, we've already covered the first point, which is scene safety PSI. We covered, or in this one, we should cover the next 6 or 7 points on your state exam sheets. Go over that when we see it. This is a primary survey. One of the most important things we do because of the first point there. Focus on life threats. During the primary survey, this is where we figure out if the patient is what we call stay and play or scoop and screw. So
Scoop.
scoop and screw. Scoop and screw. Life threats. Anything that's going to affect airway, breathing, or circulation are life-threatening emergencies. If the patient loses their airway, breathing follows pretty fast. And if we don't have an airway and we don't have breathing, circulation's just not happening. And circulation, that's our heart rate. So
Is
all
that where,
these, yep, go ahead.
I would say, is that where CSMs come in place?
No, that's different. That's when we're checking for ability to feel and move your arms, legs, and fingers. That's a little different.
Wait, there is an assessment today on these chapters?
Do you guys have a quiz today on this?
No, like, there's a, today you said you're handing out a test?
No, I'm giving you the state exam sheets that the
Oh, okay.
examiners will use to grade you guys during your exam. So over there you have all the sheets and you can start studying them now.
Okay, I thought you were like saying a test 'cause I know we have a test scheduled soon.
No,
So.
there's, not to my knowledge, there's no test today.
Okay, thank you.
Not to my knowledge.
That
Are
means they're
we doing the CPR test today though? We didn't
Yeah.
finish it yesterday.
Yes, we're gonna do CPR today. So airway, breathing, circulation. We're gonna have to intervene if we see an issue during our primary survey. And the order that we intervene is the order that you see right now. We got to correct an airway problem before we can correct a breathing problem. We got to correct breathing problems before we do circulation problems. We see problems like this going on, we're going to need all hands on deck. So airway issues, was it 2 days ago? We showed you how to manage an airway with an NPA and an OPA. That's going to require 2 people on airway. Airway always gets a couple of people there. Breathing, well, we taught you how to use the BVM. We will show you guys how to use a non-rebreather mask or a nasal cannula to fix a breathing problem. We did teach you how to fix the circulation problem. That's CPR.
I was just going to ask you about that.
Mhm.
Like, what is exactly is a circulation problem? To me, I see circulation as in like, is the blood flowing? Is there capillary refills? That's what I was thinking about circulation.
And you would be 100% correct.
Oh, okay.
100% correct. If we got a first, heart needs to be beating. Second,
Yes.
needs to be beating good enough to keep somebody alive. So too fast, too slow, not strong enough. We got to do some things to correct that.
This might be a dumb question because we definitely took the
Probably
CPR
is.
CPR class yesterday, but if a heart is beating too fast, what do you do? Do you do? It's just a dumb question, but do you do CPR to? No, but like, what do you do if a heart is beating too fast? Is there a certain medication that needs to be given, or like what can an EMT do in that matter?
An EMT is going to do two things. One, you're going to start driving to a hospital, and two, you're going to invite me to the party,
The paramedic.
the paramedic to the party, because we do have meds that can slow that heart rate down.
So if I know in some instances you can call ALS, but because we showed up first, are we the ones in charge of transporting patient, but we just have to have a paramedic on board with us? Or do we have to give, if we were still on the scene and ALS had pulled up, do we now transfer the patient to ALS?
That's going to largely depend on a number of factors. If you're already, most of the time, you should be loaded in your ambulance. What I'm going to do is I'm going to show up. I'm going to grab my drug box, my monitor, and my first in bag. I'm going to hop in your truck with you. I'm going to start doing my ALS stuff, and I'm going to tell you guys to drive me to hospital.
And
That's
you
right.
got, the only thing we can do is assist you
Yes.
in providing the medication. We can't give the medication ourselves. We don't even have those on BLS trucks, right?
Yeah, you cannot give those medications.
Okay, thank you.
Mhm. All right. Forming a general impression. This is where we're just going to take a look at the patient and we're going to see, what does this patient look like? I'm walking up to this patient. They look warm, pink, and dry. I like it. They look blue. I don't like it. They look like a shade of gray that should not exist. I don't like it at all. Mental status. We talked about a person being conscious, alert, and oriented to person, place, time, and event. Person, they got to know who they are. Place, they got to know where they are. Time typically means, do they know the day? Date, what day of the week it is, the month, stuff like that. Do we need to know the specific minute and second? Not necessarily. Event, do they know why we're here? If we're not ANO or CIO ×4, then something's going on with the brain. It's not being perfused correctly. Airway. Patient is talking to us, probably means that their airway is patent and they can maintain it. But I'm looking in their airway, I hear some gurgling sounds. I got to address that. We suction that. Breathing. We're looking for stuff that's too fast or too slow or not adequate enough. Equal chest rise and fall. If it's not equal chest rise and fall, that's a problem we got to fix. Labored breathing. Labored breathing just looks like a person is struggling to get air in and out. Wheezing. If we can hear wheezing, we got to correct that. That means that their airway is not, or their breathing is not good. Go back to that blue patient. They don't have enough oxygen. We got to give them some oxygen there. Circulation. We're looking for that cap refill we talked about. We're looking for a heart rate. Too fast, too slow, too weak, too strong. Regular pulse, irregular pulse. From there, we're going to determine a patient priority. Let's think about a patient who's blue, altered mental status, got some gurgling respiration, struggling to breathe. Are we thinking this is a high priority patient or a low priority patient?
Probably high.
Very. We got a patient who's warm, pink, and dry, talking to us. Maybe they're a little bit altered. We high or low priority?
Low.
Anybody want to make an argument for high?
I mean, if they're a little altered, then maybe their mental status is not too great.
Mm-hmm.
Well, then in that case, would it be like almost like a medium priority? Like, I know in triage you do like black tags, yellow tags, and what, like black, yellow, red, and green or something like that. But in some cases, like a green light, you do green is low, yellow is like a medium priority, and red or black is a high priority. So would that actually, because they look physically okay, but their mental status is altered, wouldn't that be like a medium-ish priority?
It's a trick question here. In Massachusetts, for the purpose of your state exam, all of your patients will be high priority patients. In reality, that person who's warm, pink, and dry may be a little bit off with their mental status. I'm going to say it depends. Depends on a lot of things there.
I have a quick question.
Yep.
So I know like the standard is warm, pink, and dry. Now, what about a darker skinned person? They're not going to be pink, so I'm a little confused.
Yeah, so the color, when we say warm, pink, and dry, it's a little bit misleading. Pink just means normal skin color.
Okay.
For darker skinned patients, look at their nail beds. You can always look at their mouth just behind their lips and see if that looks normal or not. But yeah, the word pink just means their skin color looks normal.
Okay.
Right. General impression. So we already talked about last time for our nature of illnesses, the chief complaint, and that's why the patient calls EMS. But for sometimes we go for an unknown medical and we don't know why they called. So this is where the clues come in. Look at their environment. Oftentimes we will be picking up people on the side of the road when it's cold out. Yes, they're drunk, but we're here in New England and it gets cold pretty fast in the season. Got to start thinking about hypothermia at that point. We got to start thinking about, I mean, look at today. Yesterday it was 90 and humid. We're picking up the drunk on the side of the road. We got to think about high temperatures at that point. So.
In the case of like, it's during the marathon bombing, it was like, even if you're an EMT during, something like that, and, phones are down, things are down, there's calls coming in like crazy, what like, and we can't get in control, like in contact with med control or, our like dispatchers and stuff like that. Because, sometimes some of those things go down during, natural disasters or during terrorist acts, and we can't get in contact with them. Can we act as, obviously we act in the scope, like I don't know, like in those instances, if our only option, because we can't contact for ALS, are we allowed to, if we can do whatever it takes, even above our scope of practice, to save a patient's life, or we shouldn't ever try that, even if it was life or death for a patient?
From understanding what you're asking, the answer is no. You cannot operate outside of your scope of practice unless you've been ordered to by a doctor.
Okay.
Take a look at this guy. What do we think's going on?
Heart attack, cardiac arrest,
You could be joking.
stroke.
Could be joking. I heard stroke. I heard cardiac arrest. I heard heart attack.
He could be diabetic and his blood sugars are way off.
I like that too. Could this
Slip
be
and
a
fall?
slip and fall? I like that. Do you see how much stuff we just came up with just by looking?
Yeah.
Yeah.
That's what we call the look test. We just saw the patient, we got no other clues, and we're already thinking about multiple things that could have caused this guy to be on the ground. Based on this picture, I'm assuming he's probably at home.
Yeah.
The rug there looks clean, so I'm assuming he's in a well-kept home.
Or a nursing home?
Could be a nursing home too. Absolutely. Absolutely. So we call that the look test. That's us looking around. And like it says there, feeling from environmental observations as well as looking at the patient first. Key point, look at the patient first. That's going to give you most of your clues. Environmental clues come second.
You okay, Brutus? Come here.
All right, findings that indicate a critical patient. Altered mental status, big key. Patient who's altered, their brain's not being perfused for whatever reason. Either they're hypoxic, there's not enough oxygen available. They don't have enough blood going up there. They don't have enough sugar in the tank. That's the big thing. I'm not so sure about anxiety, but I will tell you, especially when you get into the anaphylactic shock lecture, anxiety or the patient says that they're feeling like some sort of a feeling of impending doom, usually that's not a good sign. The patient knows they're about to go in the wrong direction. Pale, sweaty skin. Pale, not a good look on a lot of people. Sweaty skin, I'm not talking about normal sweat like it's hot outside. I'm talking about what we call diaphoretic, just profound sweating that is uncontrollable. Oftentimes, we're going to see that in our patients who have low blood sugar. We're going to see that in our patients who are having heart attacks. Head trauma, chest trauma, abdominal trauma, pelvic trauma, any trauma to the head could affect the brain. That's not good. Trauma to the chest, that's very close to our heart and our lungs, two very vital organs. Our abdomen has a lot of blood vessels running around there. We can bleed out pretty bad. Pelvic trauma, it's often overlooked, but your pelvis is something like 25% of your blood, I believe, if you break your pelvis on both sides. So a quarter of your blood loss is definitely not good. Other things we can look for is something called a tripod position. Imagine a patient sitting on the edge of a chair with their hands on their chair between their legs and struggling to breathe. That's our tripod position. You will see that in asthmatics, you'll see that in your COPD patients, and you might see it in some of your congestive heart failure patients, but definitely the asthmatics and the COPD patients. Tripoding is the patients trying and struggling to get air into their lungs as much as they can, but they just can't because their airway is collapsing. Just understand that these signs don't always mean that the patient is unstable, and lack of these signs doesn't mean that the patient is stable. You know, we could have a patient who looks perfect until we do some sort of a vital sign test, and maybe at that point we get someone who's got a blood pressure of 250 over 180. They probably look normal, but that's not a normal blood pressure. That person's not really stable. Keep some of that stuff in mind. Any questions? I think it goes without saying, patients who appear lifeless, we need to start CPR immediately and grab the AED. But there are people out there who don't understand this concept. Anybody have any questions on this? Look, listen, and smell. Look at the patient. age, sex, and position. We talked about tripod, old or young, male or female. Listening, gurgling respirations, snoring respirations. That means we got an airway problem. A moaning patient, probably in pain somewhere. Smell. Well, I think everybody knows what urine and feces and vomit smells like. That's usually not good on patients. Decay. It doesn't smell good when you walk into a patient's house who's decaying. Does not smell good. Eventually, with time, you guys will develop what we call a sixth sense. And the best way I can describe it is you just walk in and you take a quick look at the situation you're in, and you're going to know right away whether this patient is stable or unstable. It takes time. It's not something we can teach. Just got to put your time into the truck and it will eventually develop itself in you. Any questions on that?
Nope.
Great. Chief complaint. More often than not, complaints are very specific. I called 911 because my chest hurts. I called because I can't breathe. Called because I have a headache. But then we always have those patients who call for the non-specific, I don't feel good. Those are the patients, the I don't feel good patients, not feeling good. Those are the ones where we got to become detectives and figure out what's going on with the patient based on what they look like, based on what they sound like, and based on what we find with the vital signs. I will tell you on a personal note, I would much rather go for the patient saying I'm not feeling good than the patient who is telling me I've got chest pain. We're all guilty of it. It's called tunnel vision. When you show up and you know what the complaint is ahead of time, you usually put the blinders on and you're only focusing on that one thing that could be wrong. At least when the patient just says non-specifically, I don't feel good, you got to start thinking about everything that could be wrong. Questions on that? One more time, Jessica. I think you said something. I couldn't hear it though.
No, that wasn't me. I'm sorry.
Okay. Mental status. On Tuesday, I taught you guys about AVPU. This is how we determine somebody's mental status. What we like to see is alert, person, place, time. It doesn't say event there, but they should also be alert to event. That means we're good. They're altered if one of these criteria is off. A person who is only alert or only responds to verbal stimuli, you shout at the patient, something's going on with their brain there. Painful response, that's the patient you have to do a sternal rub to, got to pinch their earlobe, or just do something sort of painful to a person to elicit a response. Hopefully they open their eyes at that point and start responding to you. Oftentimes, if they're only alert to a painful response, they're not going to open up their eyes, they're just going to start to posture. And unresponsive is unresponsive. Nothing you do elicits a response from the patient. Let's do a little thinking here. Let's say we're going for a patient with dementia or Alzheimer's. What kind of things are we going to expect from these patients?
A delayed response or a confused response.
I like it. If they're a confused response, does this necessarily mean that they are altered?
No.
No. But
Yeah. This doesn't confuse me, altered.
They have dementia though. At baseline, they're confused.
so also when you pull up to scenes like that, they, an adult could be speaking as if they were a child or from a past or present event, but you'll never really know with dementia patients because some have long-term memory and short-term loss, or short-term memory and long-term loss. So you may never know exactly everything and anything that happened while for the reason of the call. And it could also possibly be you showed up on scene and nothing's wrong, but it was a dementia patient or Alzheimer's, and they called because it could be an attention thing. There's a lot of factors that go into dementia and Alzheimer's.
All correct. That's why it's important on scenes to try to figure out what is the patient's baseline. If I'm going to pick up an Alzheimer's patient and I'm told at baseline, this patient only knows their name, and I assess them and they only know their name, they're not altered at that point. They're acting appropriate to their baseline. We should expect that. I'm showing up to pick them up and they don't even know their own name. That's someone who is altered. They've deviated from their baseline. ABCs, yeah, I said varies depending on the patient's condition. We always do ABCs in that order. Patient who's speaking to us, airway is probably clear. All right. For medical patients, we do a head tilt chin lift to open up the airway. For trauma patients, we will teach you guys, I think next week, how to do a jaw thrust maneuver. The reason why we can't do jaw thrust on trauma patients is because we have to assume that there is a C-spine injury, and a head tilt chin lift does put stress on the C-spine. And as we can see in this picture, there was something in this guy's airway, and now it's being suctioned out. We will have to suction. That particular device you see in the picture is called a Yankauer suction catheter. I don't know how to spell it. I can show it to you guys when you come here though. You suction while you remove the catheter from the patient's mouth for no more than 10 seconds. So we don't suction going into the airway, we suction while we pull the catheter out of the airway.
Would that be with us too? Is that BLS?
That's BLS. Absolutely BLS. I just said that. No signs of trauma, head tilt, chin lift. You guys learned that yesterday in CPR. Signs of trauma, jaw thrust. Stand by on that one until we do trauma next week. Breathing. Respiratory arrest. They're not breathing. We got to fix that. We know how to fix it. We have a BVM. Inadequate breathing. Might be a BVM situation, might not be a BVM situation. Sometimes we're just going to throw a nasal cannula on the patient, give them a little bit of oxygen. Sometimes we're going to give them that non-rebreather. Questions on breathing? Circulation. Yes, we got to look for a pulse. Carotid pulse and radial pulse are our two go-to pulses that we check. For our infants, we check a brachial pulse. There's also femoral pulses. On the trauma patients, you will learn about the pedal pulse, which is down on somebody's foot, on the top of their foot. There's no need to check all those pulses on most patients. Oftentimes a radial pulse is sufficient. Skin, color, temperature, condition, that's the pale, cool, diaphoretic, or the pale, cool, yeah, pale, cool, diaphoretic if they're not good, warm, pink, dry if they are good. We don't do temperatures in the field, so you're completely taking a guess as to whether they feel normal or whether they feel too hot or too cold. use the back of your gloved hand, put it on their forehead, and that's how you assess skin CTC for the state exam. And then we have bleeding. We're just taking a look for any external bleeding. We got to address external bleeding and stop it before it becomes a major problem. We will talk about bleeding control in trauma lectures. Questions on that? Three results. Heart rate's within normal limits. We're happy. Heart rate's too slow or too fast. We're not happy. Who can remind me from Tuesday how I said we count for pulses? What are the different number range or math things I gave you?
15 to 2.
That's compressions.
Yeah, I just went over that.
15 times 4, or 30 times 2, or 10 times 6.
All of those. What's the most accurate way?
1 to 60.
Count for the full minute. And
Count
what's
for
the
the-
least accurate way?
Dividing by 10.
The
Times
10 by 6.
Yes, count for 6 multiplied by 10.
Now, if we did a 10 by 6, right?
Mhm.
And like that was the easiest way for us to do it. Are we gonna get in trouble for using 10 by 6 on the at our EMT?
Nope,
Okay.
not at all. Skin, as if we haven't beaten this enough. Warm, pink, dry, we like it. Pale, clammy, diaphoretic, we don't like it. Best way to describe clammy skin is it's cold and wet. Immediate intervention. Like I said, as soon and during this whole primary assessment phase, we see a problems with airway, breathing, or circulation, we have to address it before we move on. These are the problems that will kill a patient within 5 minutes. So keep that in mind. Questions on that?
So change your color.
Patient priority. So a stable patient, vital signs are good. We like them. ABCs are clear. We like it. They're stable. An unstable patient, ABCs, and I'm going to add to this, vital signs are bad, or ABC's got a problem or our vital signs have an issue. That is an unstable patient. A patient who is potentially unstable will deteriorate pretty fast. Just be aware of that. You can show up, the primary assessment can be spot on perfect. 10 minutes later, they're crashing. It can happen even on the simplest of calls.
I'm sorry.
Don't worry about it. It's all good.
So even if a patient is stable, like with like the vital signs, but what about if like blood pressure's low or high or anything like that? Like, does that like cause are we only checking when for patient priority when the vital signs are normal, or do we have to check for everything, right? Before we can say that a patient is stable?
Yes, you have to check everything before you make that determination. Priority transport. We figured out that we got a life-threatening situation and we can't control it in the field or the ambulance. This is a high priority patient. You will always continuously reassess patient while you're going to the ambulance. Patients who are unstable, you will reassess every 3 to 5 minutes. Patients who are stable, you will reassess every 15 minutes. And as I said, for the purposes of your state exam, they are unstable patients. So it will be every 3 to 5 minutes, and they will always be a high priority patient that you will get. Any questions on that?
If you get a patient, let's say, is just on for a transfer, do you have to do because like they're obviously low priority, do you have to continuously, like, let's say I'm taking a patient from the hospital and bringing them to New Hampshire. I mean, that ride is definitely longer than 15 minutes, probably more 30 to 45 minutes, maybe even up to an hour. But do you still have to, like, if it's just a transfer, do you have to, like, consistently every 15 minutes take vital signs?
Yes, you do. Absolutely. Now, if the patient tells you they don't want you to do it, that's another story. Patient can tell you, don't touch me. You don't touch the patient, but ordinarily you should be taking vitals every 15 minutes on calls like that. All right, let me see here. Different patients are going to require different assessments. Medical patients is the first assessment you guys are going to learn. Then we'll learn the trauma assessment, which is very different from medical. Mental status, we're asking the questions, do you know who you are? Where are we? What day is it? Why are we here? That's how we do our mental status. Child or adult? Do we think that kids are going to be able to answer most things we ask them?
No.
Depending what age they are,
It does depend on the age.
they won't be able to answer you correctly, but perhaps like a 7 or 8-year-old might be able to tell you exactly where it hurts.
Absolutely.
Yes, Ezekiel.
Absolutely. And while we're on the topic of kids, let's give a little pediatric note here. We really have to adjust how we assess kids, because what do kids usually associate medicine with?
Gross.
Needles.
Gross, needles, that's the big one. They go to the doctors, they get the needle, they don't like that. So we will have to change how we assess our kids. We're not going to hover over kids. We got to crouch down to their level. We got to use our terminology in a way that they can understand it. We're not going to sit there and start asking the kid, do you have chest pain? They don't know what that means. Point to your chest and look at the kid and say, does it hurt here? And they're going to tell you that. Point to your head, does it hurt here? And they'll give you those answers. Questions? Primary assessment. Form the general impression. That's the first thing you do. Figure out their mental status, clear their ABCs, figure out your priority for your transport. When we learn the medical assessment station, all of that will make sense. So tell me, how do we assess Oh, wait a minute, different place here. Yeah, what factors are you going to take into account when forming a general impression of a patient? Who wants to tell me about that?
How they look,
Yeah.
what position they're in, the yes, honey, I know, I see that.
Their mood.
All of the above. AVPU, what are we doing there? What does the A mean?
Alert.
Alert.
Alert. What does the V mean?
Verbal.
Verbal.
The P
Pain.
Painful,
and the U?
unresponsive.
Unresponsive. Good. How do we figure out, how do we assess airway, breathing, and circulation?
Airway, we look to see how they're breathing or if they're breathing. If there's anything trapped in their airway. If there's anything compromising their airway.
Go ahead.
Good.
Wait, what? Trust
So,
maneuver. Check
so Rose has something to say.
blockage. Wait. No. She already said it.
Okay, never mind.
All right, how do we do breathing?
See if their chest is going up and down, or if their nostrils are flaring.
Mm-hmm.
We expose the chest. We see if there's any open wounds.
Yeah.
Any closed wounds.
We open up the chest and look for rise and fall, put our cheek against their mouth, not up against, but like close to their mouth to feel if they're breathing out, or if we feel any type of air on our faces.
Circulation, how do we check that?
Check the pulse.
Checking pulse.
Look at their skin. If it's warm, pink, dry, or pale, clammy, and moist.
That was Rose.
Yep, look at skin. All
So
right.
check for any interior bleeding.
Check for bleeding. Good.
Do we also check the back of the hand and
Yeah,
forehead?
so it'll be the back of your gloved hand and you'll put it right on their forehead.
All right. And what about temperature?
That's you taking a guess. Do they feel too hot, too cold, or just right?
All right.
Priority decision, I'll tell you guys what that means. Literally means determination of the need for immediate intervention or transport or both. Basically, priority patient, we found a problem with the ABCs or their vital signs, and we don't like it. Think about this guy for a minute. We walk up to a middle-aged male lying on the street after being hit by a car. Patient is unresponsive. You notice he is bleeding from a laceration on his forearm and making gurgling sounds. Think about that for a second. And tell me, what are you doing first?
Clear
We're
his
looking-
airways.
General impression.
50.
First of all, you can't do the head tilt because you don't know if there's spinal injury. So you want to check for a pulse. Well, no.
Well, because he's gurgling, wouldn't you want to put an NPA because it sounds like his or depending because if he's unresponsive, he might still have a guy reflex depending on OPA just because it doesn't sound like his airways are clear.
His airway is not clear.
Yeah.
But we hear gurgling, so that means that we got some fluid in that airway. What are we doing?
You use the jaw thrust
Secure the
maneuver,
airway.
Hmm.
but also it could be like when he was hit, he
Suction.
had some type of like, and he has some type of internal breathing. It's not a choking, but he has some type of airway, like he's bleeding internally, and that's why he's gurgling.
I heard somebody say suction.
Oh,
Remember back to that picture, the guy was on the ground, there was that yank hour in his mouth. That's what we got to do to this guy.
Suction and then secure his airway with an OPA.
Absolutely.
And then we treat the laceration and get moving.
Yep,
Scoop it through.
you got it.
in that case, you don't pack the wound first.
Yeah, we're not
You
packing.
always pack the wound first.
A laceration is not a wound. That's like a laceration, like something, a cut.
A laceration is just a cut. We're not gonna, hopefully we don't have to pack a laceration. We're just gonna put a little bandaging over it.
Okay.
Well, the first thing we got to do is we got to suction, because a gurgling airway is not good. All right. Anybody have any questions? So we still got time. We're gonna try to bang out one more lecture. I'm gonna go grab Tommy though and get the marching orders for how we're gonna do that lecture. Stand by. All right, here are the marching orders. We're gonna take 10-minute break, be back at 10:55, and we're gonna do chapter 2, workplace safety, and then we'll be done until 1. Sound like a plan?
Yes.
All right. See
Yes,
everybody?
thank you.
Yeah, see everybody in 10 minutes. Everybody here?
Yes, we're here.
Yes.
Like it. Workplace safety and wellness. Is anybody familiar with the 5 stages?
I know. Is that like the grief stuff?
Yep.
One of them is like bargaining. One of them is denial. I forgot what the rest of them are. Acceptance, I guess. Denial, anger, bargaining, depression, and acceptance.
There you go. So EMS, we're going to come into death and dying. It's the nature of the job of medicine. There's going to be multiple, as this goes, there are multiple stages to this. Denial, the patient refuses simply to accept what's going on. Anger, patient goes on the attack. They'll probably lash out. Bargaining, this usually is when the patient is trying to make a deal, whether or not anybody, I'm not getting into opinions or anything, but usually patients start to make a deal with God to keep them alive longer. Depression, reality sets in, patient becomes depressed, and then they accept it and they move on. How do we handle these? We need to be empathetic. We need to listen. We need to have good communication skills with all these patients. That's dealing with the patient. How do we deal with the family and the bystanders? Simply maintain the patient's dignity. We're not going to make any negative statements in front of the patient. Talk to your unresponsive patients as if they were still responsive and can understand what you're saying. Show respect at all times. Explain what you're doing and why you're doing it. Communicate. Tell them everything that is going on. Allow them to express their emotion. Cry, vent, grieve appropriately. You listen empathetically. Keep a straight face. Never give a false reassurance to anybody. Never do that. It will come back to haunt you. Speak in a gentle tone of voice. We're not going to get in their face. We're not going to start arguing with them. We don't do anything. Ask if there's anything you can do for the family or the patient to help comfort them. Do we think EMS is stressful?
Yes.
Very stressful. Very stressful. You got to find a balance between EMS, the stress of work, and your life.
What about
Some
if my life is already stressful? Zeke!
got to find that balance. Got to find that balance. Some stressful things we go to. MCIs when we got multiple patients. Emergencies involving kids. All of them are very stressful. Even the most simplest of calls with kids are very, very stressful. Injury and or death of a coworker. I've been in this business for almost 7 years, and I've gone to 5 coworkers' funerals. That's not good. Abuse?
You guys lose anybody to COVID?
No. No one to COVID.
Good, thank God.
Abuse, domestic disturbances, all that, very stressful situations. Reactions. How do we react to things? Well, we can have an acute reaction to it, which is very high stress situation. We can develop our chest pain, our own shortness of breath. We may have some cognitive, behavioral, physical impairments in the acute setting. Delayed stress reaction, this is our PTSD. It happens, and you gotta find help for it. You gotta seek the balance for it. Obviously here it looks like we have a kid involved in some sort of a trauma situation. You know, we're not gonna lose it on scene, especially since the kid can still see us and probably hear us, but we might lose it later on once we drop this kid off at the hospital. This often leads us to burnout when everything builds up over time, and it's very important to never let things build up. If you got to talk to somebody, you got to talk to somebody. Unfortunately, we're in a culture of EMS and first response where we're taught it's not okay to talk about your feelings. And when you bottle things up, eventually there's a breaking point. That breaking point could be you take it out on your family, you take it out on your friends, you take it out on yourself, you start drinking, start doing drugs, maybe you kill yourself, commit suicide. The point is, do not bottle it up. Talk. There is no shame in talking about any situation. Questions on that?
What if you do reach out to someone like within your profession about how you're feeling and they pretty much like shame you for feeling how you're feeling? What do you do next? Do you just like speak to someone else? Do you seek someone outside of work? Like, how does that work?
We here at Cataldo, we do have a peer support group that you can always reach out to. It is 100% confidential. You can always reach out to the supervisors whose job is to also maintain confidentiality. If, you know, reaching out to your coworkers, if they want to shame you, from my experience, if they're going to act that way, that means that they're feeling the exact same way you're feeling. They're just not brave enough to admit it. And I would say a person who admits, I'm struggling with a call that happened, I'm having flashbacks to it, I've been hitting the bottle one too many times, I would say that person is very strong for wanting to talk about what happened. You know? Signs and symptoms of stress. Irritability. Can't make decisions, you lose interest in things, you can't concentrate, guilt, anxiety, loss of appetite. It builds up over time. How do we manage this kind of stuff?
We can seek help, therapy. We can do exercise.
I like it. Exercise, that's a big thing. Relax,
Go on vacation.
take a vacation, that's good. Eat a healthy diet. You guys will eventually see just how many times EMS goes to McDonald's, Burger King, all the fast food places. Not the healthiest of situations. For whatever reason, EMTs and paramedics like to drink Monster Energy like it's going out of business. I don't understand that. And they love to drink coffee at all hours. Caffeine's not very good. It doesn't do good things. Well, in moderation, it's fine, but at the rate some people drink it, not good. Avoiding self-medication. You know, there's no need to hit the bottle. There's no need to do any of that. Talk about it. Questions on that? Keeping a balance. Think about what your priorities are in life. And this is something you can do on your own. Figure out what is your top priority, what's your second, what's your third priority. And understand that it's a balancing act between all of our priorities. You got to figure it out. It's very easy to take this job home with you. It is not easy to leave it at work. You got to do your best. You know, finding people who are just like you working in this field to talk to is the best way to go. You can also reach out to a place called Onsite Academy. It is a free service in the state of psychologists who specialize in dealing with first responders. They will absolutely help you out there. You also got to accept the fact that we're going to make mistakes. We're all humans. We are going to go to that call someday and we're going to overlook something that was wrong with the patient, and the patient's not going to have a good outcome. No one is perfect. You got to admit you made a mistake and you got to move on. You'll go through retraining. Everything will be just fine. But when you go into calls or go into this field thinking you're never going to make a mistake, that is the quickest way mistakes happen. Do you think that our family and our friends who are not in EMS understand what we do?
No.
Not to the full extent.
Do you think that doctors and nurses understand what we do?
Yes.
Definitely not. I don't think so. Well, I think they're aware of like high stress situations, but as far as everything we do, I don't think so.
To like a certain extent.
I think they can sympathize. At least emergency ER docs.
Definitely in the ER, they've got a better understanding, but most of the time they don't understand what it is we're doing. So family and friends are probably going to experience a little bit of the same stress you experience simply because they don't understand. They don't understand what's going on. There's that fear of separation. We're working long hours. Sometimes we do 24 hours on. It's a long time to be at work, and they're exhausting hours. We put the uniform on. You know, there's no guarantee we can come home. We might put that uniform on, go to that highway call, and somebody's not paying attention and they hit us, they hit the fire truck, they hit the police car. How many times do we hear about that sort of stuff? That's why the move over laws exist in Massachusetts. That's probably the biggest reason why family is stressed out about us working in first response.
What about in this COVID season? What about like catching COVID and already having some underlying issue, like a diabetic or whatever?
Absolutely. They are very afraid. The best thing we can do in this situation is do our best to explain and understand where our family and friends are coming from. All right, how can we change our work environment? Anybody know what a buddy system is?
Picking somebody and sticking with them, like changing, like your partners?
Absolutely. Find a couple of coworkers who you're going to be buddies with. You keep an eye on each other. Let each other know, hey, you're looking a little stressed out today. Maybe you should take a day off. Maybe you should take a little vacation there.
Doesn't really work that way though. Well,
Try it.
like, does your buddy say, "Hey, well, you're looking kind of stressed out. Perhaps you need a Friday off"?
I would take it.
He said I would take it.
All right. Request a rotation of duty assignment. That's difficult to do. You can always request it. Hopefully it'll be allowed. Oh, sometimes it won't. Exercise, that's a big one right there. Seek professional help. Don't be afraid to seek mental help. It's not a sign of weakness. This was that peer support group I was talking about in the on-site academy. Never be afraid to reach out. It's not a sign of weakness, like I said, no matter what anybody says. Critical incident stress management. This is something that is implemented whenever we do a pretty serious call. Typically, what will happen is we go on the call, and then at the hospital, you're going to meet with the supervisor, and you're just going to, or maybe back at the base, you're going to debrief what happened on the call. Supervisor is probably also going to go speak with the fire department that was there, the police that were there, the deputy chief is getting involved, the chief might get involved. You know, we try to do it as close as we can within a day or two.
Would this be like a baby's death or finding somebody decapitated? Is that type of
Yes,
scenario?
those kind of calls, pediatric cardiac arrest, that kind of stuff we're going to go talk about. MCIs we're going to talk about. Those are all critical incidences.
Oh, MCI is critical incidents. Okay, MCI. So that,
MCI, mass casualty incident, but that along with pediatric arrest or something like that, those would all be considered critical incidences. These are usually not very structured meetings. It's just everybody's gathering around like you see in this picture here and just talking about what happened and debriefing what happened, what went good, what didn't go so good. We're not pointing fingers at each other, trying to tell people who messed up on a call. We're just debriefing. We're letting it all out. Scene safety. All right. How do we protect ourselves from diseases? We got a lot of nasty things out there. Bacteria, viruses, fungus,
mask.
protozoans, worms. Yeah.
Mask.
You're
What
vaccinated.
Mask, gloves, all that stuff. Face protection, gowns. Do it. Don't try to be a hero, just put it on. You will find medics who start IVs without wearing gloves. It annoys me. Put gloves on. People are nasty. Even if you wore gloves, you should wash your hands after every single patient contact. I know the slide there says 10 to 15 seconds. Do it for 20 seconds. Use hand sanitizer only if you can't access soap and water. Most of the time we're going to hospitals, there will be plenty of soap and water available. Hand washing is the most important way we prevent the spread of infection. We're not going to watch this putting on gloves and taking them off because we're going to do that later on. There is a way to do it. We talked about eye protection, gowns, masks. That's pretty good to protect you from everything. Those gowns are disposable. We also got to clean the truck when we're done. We do have, you guys will eventually learn the purple wipes, you'll learn the yellow wipes, you'll learn the green wipes, all that. The most common one is the purple wipes, and what that means is the box they come in has a purple lid on it. That kills just about anything. They're officially called TB wipes, but it kills pretty much everything. Disinfecting, we do have sprays. Every truck should have a spray bottle on it of some pretty powerful disinfectant. Sterilizing, we're not doing that in the truck. That requires a lot more cleaning and availabilities than we have to do.
On the topic of the like wiping stuff down, if you're allergic to any of those, do you just have your partner do it? I know it's usually a two-person job. How does that work?
Have your partner do it.
Okay.
Immunizations, you are required to have pretty much all those immunizations there up to date to work on the truck. I'm sure they'll add the COVID vaccine at some point. PPD is that's the tuberculosis test. It's not actually a vaccine. I don't know if they make us do it annually anymore or not. I know they've been changing it. Pretty much everything else there are vaccines.
They gave me a TB shot when I went in for my physical.
Oh, they did?
Yeah, it was time for me to get the
Yes.
booster, titers, something like that, because I
Yes.
had gotten it before.
All right. Reporting exposure. If you are exposed to something, and exposure means you came in contact with fluids or some sort of infectious agent without the proper PPE on, that's exposure. You know, you have an HIV positive patient, you touch the blood with a gloved hand, that's not exposure. You have to report this by law. You need to give the date, the time that you were exposed at, the type of body fluid you were exposed to, all the details, and you need to figure out the amount of fluid. Here at Cataldo, they will then send you to an ER for mandatory prophylaxis treatment, and you'll be going for blood draws every week or so, I think, just to monitor to make sure that you didn't contract anything. Certainly is
So with
not an
that,
ideal situation.
sorry.
Mhm.
With the reporting of exposure, say we do have the proper PPE on, but when we arrive on scene, there's like the patient's dog, and the patient's dog is like a little out of control. We get bit, and it does end up breaking the skin. We still report that exposure,
Yes,
or is that not too much of a threat?
you still have to report it.
Okay.
You still have to report it. Report everything.
And then-
To follow up on her question, if we were to get bit by a dog before treating the patient, do we still continue, or do we stop and immediately report in to the ER?
Stop, call the supervisor, call another truck, and follow orders of the supervisor.
And then say we were wearing PPP, but then PPE, and then we realized, oh, the blood soaked through, and that's still something that you report, and that still isn't exposure, correct? If like for some reason your equipment did fail you.
Equipment failure, you definitely be reporting. Hepatitis B, pretty common. Carriers are quite often symptom-free. You can still spread the disease. Hepatitis in any form affects the liver, go into liver failure with it. There is a vaccine against it. Wear your gloves, wash your hands, clean everything, disinfect everything. Double bag, I don't know if I necessarily agree with that. I would say just throw it into the red bags, which are for biohazard waste. Hepatitis C. Needle stick injury. Oh, what happened there? Needle stick injury for hepatitis C. There is no vaccine against it. Be cautious around needles. This is why whenever there is a needle involved, the first place it goes is right into the sharps container, whether or not it touched the patient. Once in the sharps container, it is safe.
Now, I have a
Oh,
question.
Rose has, hold on, Rose. Rose has a question. Hold on. What is it?
If an EMT gets bit or gets poked by a needle that contains hepatitis B, or a patient that has hep B, don't they get like a series of shots that prevents the virus from actually
Taking over?
Yes,
Yeah.
that's the prophylactic treatment.
Prophylactic treatment.
Okay.
Okay, thank you.
All right. TB. For the most part, TB has vanished, but it still exists out there because a lot of TB is drug resistant. Fevers, coughs, night sweats, weight loss, these are symptoms of TB. They live in lungs. TB is spread through infected droplets. The problem with these droplets are that they survive almost anything you can throw at it. One of the big things they can't survive are the TB wipes. You will need gloves. You will need to wash your hands. You will need to disinfect anything you can't throw out anything that you can. You will need an N95 mask on yourself, and you will need to attempt to put a mask on the patient as well. Not an N95, a surgical mask. You will also need to air out your truck when you are done, just because TB likes to stick around. AIDS, it's the product of HIV. Oftentimes it's asymptomatic. You can have swollen lymph nodes, nausea, fatigue, weight loss, shortness of breath, immune deficiency. It's another issue with needle stick here. It's an issue with blood that we have. It can be transmitted mother through child. Just take standard precautions. This is not something that is transmitted through the air. You don't have to necessarily mask up, but you will need to wear gloves, wash everything. And no, contrary to popular belief, casual contact will not cause someone to become HIV positive and develop AIDS. SARS, it's a respiratory virus. It is essentially what COVID is right now. Headaches, body aches, difficulty breathing, dry cough, high fever, more than 100 degrees, transmitted by droplets in close proximity. We put masks on patients. You will wear an N95. You'll have to wear eye protection because it can be spread that way, and you will have to wear gloves. Wash your hands. Never touch your eyes, your nose, your mouth with a gloved hand. Just don't touch any part of your face, even with a washed hand, while you're at work. Fastest way to get sick. West Nile virus. This is spread by mosquitoes. High fever, headache, and stiff neck are the big things to watch out for. Confused patients, seizures, muscle weakness. Does not spread human to human, so there's not really a lot of ways we can catch it from our patients. Best way to avoid it is use mosquito nets and use bug spray. Take standard precautions. Drug-resistant organisms. These are the most common things you will come into contact with. MRSA, VRE, which is vancomycin-resistant enterococcus. That is a very common thing you will see. C. diff is another thing you guys will see. Again, standard precautions, and you have to clean your truck thoroughly. Hazmats. Hazmat materials, these definitely put us into some problems. Every truck has binoculars on it. Use it as you're approaching a scene if you think you need it to figure out what's going on. Everybody knows what those multicolored squares look like on a lot of trucks and containers. We call those things placards. We do have an emergency response guidebook in all of our trucks, so you can figure out what the placard says. It has different numbers and shapes on it. You look it up based on number and shape in your emergency response guidebook, and the book there tells you what you need to do and what you need to avoid to do on these kind of scenes. It is updated fairly frequently, and we update it as frequently as possible. We don't go near hazmat patients. We send the hazmat team near them, and they will decon the patient and bring them to us. We are typically not responsible for deconning a patient. Rescue situations. That looks like a fun scene.
No.
Yes, it does. So what's going to happen on this scene, this is what the fire department is going to do. They need to stabilize that car, and they need to get the patient out before we get the patient out. We're not here to do that. They spend time at the fire academy learning how to stabilize a vehicle, learning how to cut patients out of the vehicle, and learning how to get them to us. What do? We call for some assistance. Oftentimes they'll ask us to hand them a blanket so they can protect the patient while they're cutting the patient out. They may ask you to go inside of the vehicle to hold the patient's neck for C-spine. None of us are crawling into that vehicle right there, obviously. And we got to keep an eye out for some other hazards and just keep people away from the firefighters while they address the situation there. While we're on these kind of calls, we need to wear those high visibility vests. Every truck has 2 of them. Wear them. Don't get caught not wearing them. It's a very bad phone call that you will have to make to a supervisor. That's the high visibility vest. There are some different classes there. I don't know what class we have on our truck, to be honest. But that's about what our vests look like. Violence and crimes. I think we already talked about this earlier. There's a fun scene going on right there as well. We need police for domestic disputes. We need police.
Last night I was doing flashcards and there came up the HIPAA violation. And I know on scenes, like in these cases where there's violence and crimes, there's going to be police involved. Now, I know HIPAA says that you can't disclose what is going on to anyone with a patient, but if a cop asks for his report, in the book it says do not disclose any information without a warrant. But if they're asking for the information because it was a violence or crime, what are we allowed to give them
They
like,
still
you
need
know,
a warrant.
information, but minimal information?
Nope, they still need a warrant.
Okay.
Around here, they're pretty good at figuring out that information before we even get there.
All right. Okay.
But they still need a warrant before we can tell them anything. Wellness principles, physical fitness. All right. We got to stay in shape. When we're not in shape, we're at risk of hurting ourselves. We're at risk of hurting our patients. And an injury can put you out of job for the rest of your life. Target heart rate, your age minus 220. That's your max heart rate. You can do the math there. Not overly complicated. I think your book has this in it anyway. Strength testing or strength building, that's the weight training. Endurance, that's our walks, jogging, running, all that stuff. Flexibility, that is stretching. We make sure we always lift with our knees, not our back. Back injuries are the most common injury that we get, and it puts more people out of work than it keeps in. Adequate sleep. I said we work 24-hour shifts. EMS functions 24 hours a day, 7 days a week, and it messes with people's sleep cycle. We should be getting 8 to 10 hours of sleep per day. When we don't have a good amount of sleep, we tend to have weight problems. We tend to get irritable, tend to lose concentration. Best way to sleep, cool, dark environment. Set a block that's going to be uninterrupted. No eating, drinking, exercising within 2 hours of sleep. Don't use your phone while you're in bed. Otherwise, you can throw off your own sleep cycle. EMS, a lot of people smoke. Best thing to do is to not smoke. Also, it doesn't look good when we're trying to be healthcare providers and we're running around with cigarettes in our mouth. Bad public image there. Here's another big problem, alcohol and drug issues. Doesn't get rid of stress, it masks it pretty much temporarily. It's not good to be turning to drugs and alcohol as a coping mechanism. These cause a lot more damage to your body than they solve. Many places, including Cataldo, we do have assistance programs. You have to reach out to the supervisor, tell them you need some help, and they will get you the help that you need. Reach out to
Aren't we like periodically drug tested anyway?
only if they suspect you're under the influence.
Okay.
Mental well-being. We already talked about EMS is stressful. EMS takes its toll on people. Over time, stress leads to pretty severe chronic physical and mental illnesses. Exercise, relax all the time. Engage in activities you enjoy. I can't emphasize this point enough. Don't be afraid to ask for help. It is not a sign of weakness. It will never be a sign of weakness if you ask for help. What's going on with this patient? Let's think about this 3-year-old female shot in the chest. On arrival, you find blood covering the front porch in the sidewalk. What do we do to ensure scene safety?
Make sure there's still not an active shooter.
Yep, police should be on scene.
Scene safety, BSI.
Good. Put those gloves on.
See any weapons on the floor?
Who else do we want at the party?
ALS, police,
That's there, good.
police. I wouldn't say fire for a 3-year-old, but
They'll probably be there.
yeah,
Right.
but
Why is this high stress?
because it's a 3-year-old child.
Because it's a 3-year-old child and it's a violent scene. How are we going to manage our stress with this?
Talk about it, debrief.
Good. Exercise, do what we like to do to relax. Reach out. Any questions?
No.
All right, we'll see everybody at 1.
Hold on. Rose has one. Here, go ahead.
So in a case like that with the 3-year-old, would police give you like protective vests to go in?
We actually, our supervisors carry protective vests. You can go through the training. Otherwise, no, you're not getting a vest to go in. They'll go in, secure the scene, and then call you in when they're ready.
Okay. Thank you.
All right, anybody else? All right, we'll see everybody at 1.
Thank you.
Thank you.